So, retinopathy in blood disorders. The first disorder that we'll be talking about is sickle cell disease. So, sickle cell disease is a disorder which is characterized by abnormal morphology of the hemoglobin, wherein the normal RBCs turn into sickle shaped cells. So, this can be homozygous or a heterozygous condition. And one thing important from ophthalmology aspect is carbonic anhydrase inhibitors should not be given in these conditions in the setting of sickle cell disease, as it precipitates sickling and vascular occlusion. So the changes in sickle cell disease can be divided into anterior segment and the posterior segment findings. In anterior segment findings, we'll have tortuous blood vessels in the sclera, and iris can have ischemic atrophic patches basically, and there can be hyphema following minor injuries or spontaneous hyphema in the anterior chamber. And again, mentioning that carbonic anhydrase inhibitors need to be given carefully in these patients, and IOP control has to be done, especially in case of hyphema. When we check, we have to monitor IOP and control IOP. So these are the changes in the anterior segment. Coming to the posterior segment, so the fundus finding of the retinopathy as such is divided into two stages. There's non-proliferative and proliferative stage. So in the non-proliferative stages, like in retinopathy as such, we'll be talking about it under three different headings. Mainly we'll talk about the venous, capillary and the arterial changes. So in the venous changes, we'll have tortuous vessels. At the capillary level, there is arteriovenous shunting, which is seen. Now, at the artery level, there is occlusion of the arteries. So, why is there this vascular occlusion? Because of sickle-shaped RBCs. They cannot, normal RBCs can squeeze through these capillaries and pass and supply different organs and tissues. But these sickle-shaped RBCs are rigid, and hence they cannot cross these vessels, leading to vascular occlusion. So this presents as silver wiring, and if we give 100% oxygen, then these changes can be reversed. So then other findings are at the optic disc, there will be optic disc optic disc hemorrhages are there. Then there's something called, this is a classical salmon patch. So salmon patch is orange red patch which is present in the mid periphery. It is nothing but a superficial intraretinal hemorrhage that is seen. So this salmon patch progresses to form this sunburst appearance, which is nothing but area of retinal pigment epithelium hypoplasia and chorioretinal atrophy. Other than this, we have macular depression. This is an oval depression in the macula due to which presents as irregular light reflex. Then peripheral areas of whitening and darkening are there. Then something called angioid streaks can be present. Now talking about proliferative disease. So proliferative disease, any sort of proliferative disease would involve neovascularization, as the name suggests. So here again, the first change is that there are 5 stages. So first the artery is occluded. So because the artery is occluded, now we have arteriovenous anastomosis, that is abnormal communication between arteries and veins. Then there is C-fan vascularization. So this we can see is the C-fan neovascularization, which is developing at the border of perfused and non-perfused retina. Then these are new vessels, they are leaky, so they leak and there occurs vitreous hemorrhage. Following hemorrhage will be regmatogenous or tractional retinal detachment, which is seen. So the treatment of sickle cell retinopathy is basically observation. We keep observing, and if there is any vitreous hemorrhage that has occurred, then we'll deal with that through either like IOP control can be done, and then for vitreous hemorrhage observation if it is small, and if it is big, then we'll have to go for pars plana vitrectomy. Then laser and cryotherapy can be done for ablation of the non-perfused retina, because that is the one that is leading to neovascularization and all these issues. And we can ablate the feeder vessels also. So that can be done. Vitreoretinal surgery in case of vitreous hemorrhage, which is very persistent or severe, tractional RD, etc. So this is the hemorrhage and fibrovascular proliferation. Now next, talking about anemia. So anemia is a blood disorder which is characterized by reduced hemoglobin content. So this can be hypoproliferative, it's divided into reduced production, that is hypoproliferative, or increased destruction of RBCs. So mainly how anemia causes these retinal changes is basically in anemia there can be retinal hypoxia because there's less RBC and there's less hemoglobin, so retina is hypoxic. So we know whenever retina is hypoxic, vascular angiogenic growth factors are released, vessels are dilated, pressure is released, right? So because of all of that, we have hemorrhages. Because of vascular dilatation, we have retinal edema, we have hemorrhage. Another contributing factor for hemorrhage is thrombocytopenia. And then there's also infarction of the nerve fiber layer that leads to cottonwood spots. So what are usually these changes are present in the periphery and they don't cause any visual symptoms at all. But vision affecting features in anemia can be if a hemorrhage is present at the level of macula, or there is macular edema again because of vascular leaky vessels, or there's a macular star, there's disc edema, or optic neuropathy, retrobulbar neuritis. So in this image, we are seeing retinal hemorrhages, we see cottonwood spots, and we see a boat-shaped subhyaloid hemorrhage as well. So next we talk about leukemia. So leukemia is a disorder which is characterized by abnormal production. It's a malignancy basically which is characterized by increased production of WBCs. So this leukemia is we have chronic and acute. In acute, the entire bone marrow or the blood picture is basically consisting of immature cells called the blasts. And in chronic type, we have all sorts of cells. We have mature, immature cells. A mixture of both these cells are seen. And we, based on lineage, it's chronic myeloid or acute myeloid leukemia and lymphoid or lymphoblastic leukemias. So in leukemia, we can see hemorrhages again. Then we see a special, so we see hemorrhages. So numerous flame-shaped hemorrhages are seen in the first picture, and we have subhyaloid boat-shaped hemorrhage. Then we have a very typical finding, I wouldn't call it typical, but we have this finding called something called rot spot. So rot spot is basically a hemorrhage but with a white center. So this white center is thought to be composed of this coagulated fibrin, and it's not just limited or not just specific to leukemia. It can be seen in other diseases as well, like it is seen in subacute infective endocarditis. It can be seen in anemia, in hypertension, diabetes, etc. Other than that, so this we can see is a characteristic rot spot. And we can see a few macular lesions. Macular lesions are seen in acute myeloid leukemia. Then C5 neovascularization, which is common in chronic myeloid leukemia. Then we have the image C shows leopard skin appearance because of choroidal infiltration in chronic leukemia. Then the next conditions the same. We observe, and if there is any vitreous hemorrhage post neovascularization or tractional RDs, then that is treated by laser therapy. Otherwise, as such, it's only observation. Next is hypoviscosity. So hypoviscosity is increase in number of cells compared to the plasma in the blood vessels. So this is again going to cause sort of vascular occlusion. So the conditions that can cause hyperviscosity can be polycythemia, which is neoplastic proliferation of excessive proliferation of erythrocytes, or we can have Waldenstrom's macroglobulinemia, etc. So the causes are, we can have retinal hemorrhages, as well as we can see here that the veins are dilated, they are tortuous, and there is segmentation of these vessels, of blood flow in these vessels. So this is all about retinopathy and blood disorders. It's a short discussion.